the cloud. All right, so I've just started recording this. Thanks everybody for joining us today for this journal club. This is a really interesting paper because it gets to the heart of one of the things we always ask about, which is the effectiveness of services that we deliver and trying to measure and evaluate the outcome of them, which is, as I'm sure Jess will point out, exceptionally difficult. So I will turn it over to you and let you get started, Jess.
So good morning, everyone. My name's Jess. I'm a doctor currently working with London's Air Ambulance. And this morning we're going to talk through, hang on, I can't use my slides. This paper that was published in March of this year, looking at the impact of physician critical care practitioner pre-hospital services in Wales on trauma survival. And that was a retrospective analysis of a linked registry database, or linked registry data. So just as a little bit of a background about the Welsh Air Ambulance Service. So the EMRTS of Wales was launched in 2015 and it's a physician CCP service. And its mission statement is to provide advanced decision-making and critical care for life or limb-threatening emergencies that require transfer for time-critical specialist treatment at an appropriate facility. And this includes pre-hospital critical care for all age groups, secondary transfers, enhancement of neonatal and maternal pre-hospital care, and support for major incident and mass casualty events in Wales. And it aims to bring critical care outside standard ambulance practice. So slightly different if we're thinking about LAA and what LAA tends to provide across London. So this is from the Welsh Air Ambulance 2019-20 annual report. And we can see that the total number of calls that they had in that year was 3,008. And 60% of those calls were attended by air. If we look at the cases below, about 50% of those cases are trauma. And for the same year for LAA in 2019, LAA attended 1,730 patients, 42% of those were by air. So roughly, I suppose, 50% of 3,000 patients, about 1,500. So kind of similar cases of trauma, although probably a slightly different trauma caseload if we look at what their dispatch criteria are, which is to the right. And this is from the paper in question. So I think similar numbers of trauma, but probably slightly different cases of trauma seen by both ambulance services or air ambulance service. So did the study address a clearly focused issue? And the aim of the study was to evaluate the effect of the introduction of EMRTS on a 30-day mortality in patients who had suffered blunt traumatic injuries. And as I said, this is a retrospective analysis of linked registry data. And the background for this is in 2011, Fevang et al., who were a group of specialists in physician-led pre-hospital care, got together and published a consensus process that defined the 5 most urgent topics in pre-hospital care. And this was a requirement that was felt to be necessary because of the lack of evidence-based research for current pre-hospital practice, including the utilisation of the physician within this phase of care. And so for this reason, specialists from across Europe were brought together to identify 5 key areas, and one of those main areas was appropriate staffing, looking particularly at how we can evidence that a physician-based pre-hospital care team can improve patient outcomes. And as we know, it's really difficult to get good evidence and research in this area, and that's because the population that we serve is very heterogeneous, and it's difficult to know how we can measure impact and outcomes appropriately. So it's difficult to know whether there's any direct evidence that can actually link patient outcome to specific staff members present, and is it ethical to remove those staff members if we kind of anecdotally know that we feel that we bring excellent care to those patients that we're serving. So what do we know? Sorry.
I just had a quick question for you, Jess, about so whether you think, so I guess question would, do you think it was a clearly focused question? And is the question that they're asking the question that their methodology answers?
So I think it's a very broad question that they're asking, but I think that the reason they're asking it is specifically because they want to look at a physician-based team and whether that can improve patient outcomes. So I think the question they've asked has to be quite broad, because the evidence to date, well, prior to this, was very conflicted about whether the physician, the HEMS service has actually brought mortality benefit to patients pre-hospitally.
Can you go back one slide?
Yeah.
So in their question that you quoted there, does it say anything about physicians?
No, it talks about the EMR-RTS, but they are a physician CCP model.
Right. So I think one of the things that's important for this type of analysis is to think about what they're actually evaluating a service. They're not evaluating a specific staffing model. So it's like when the other types of investigations of bundles of care in healthcare. So when you investigate a central line insertion bundle and you look at, you're looking at all of it together, and you can't really pick apart the pieces of it. So they've introduced one new thing here, but it's not just one new thing. They've introduced an EMRTS service, which is a whole bunch of pieces. It's like saying, in a central line bundle, it's the cap that you're wearing, or the full draping, or the chlorhexidine, or no one entering and exiting the room during the procedure. Which one of those things is it that made the difference? So I think it's, I think there's a tendency for us, and because they describe it as a physician-led service, to jump to that part of it, but they're quite clear in their statement that what they're looking at is they're evaluating the introduction of EMRs. And one little bit of it is that it happens to be a physician. So I think I would be cautious not to overemphasize or tease out too much just that one little bit of that whole package that they're introducing, because the CCP role and everything is also new in there. It's the team, it's the whole thing that they're introducing.
No, I totally agree with you, and I think that that's what we shouldn't do. I was like, one of my final slides is to say that I think that we should definitely not use this as a paper or evidence to suggest that there is a role for physicians within the pre-hospital environment. I think that this is evidence that a critical care team is useful in a pre-hospital environment, and then you can argue what a critical care team is, whether that is a physician CCP or whether that's a dual CCP team. And I think that I totally agree.
Why don't we get to that discussion at the end then?
At the end, exactly. So how did they collect the data and what did they look at? So they used something called the SAIL data bank, and this is a data bank that is a national data safe haven of de-identified data sets about the population of Wales. It was developed by the Populated Data Science Group of Swansea University, and it's made available in anonymized form to researchers worldwide. And so they use data from this SAIL data bank, and also information gathered from TARN, the Welsh Demographic Service dataset, the EMRTS data, and the Office of National Statistics. And they included patients who had an ISS of greater than 9, of all age groups, blunt trauma only, which is important if we're thinking about this in relation to LAA, and importantly, patients only admitted to TARN participating hospitals. Mike, did you want to say anything about the SAIL data bank?
No, other than I wish that they were everywhere.
So their primary outcome was to look at 30-day mortality in patients attended by EMRTS versus standard pre-hospital emergency services. And they looked at some covariants in their subgroup analysis, which were age, sex, ISS, intubation, GCS, socioeconomic status, and comorbidity. So their results were, they looked at 4,030 patients in total, 412 of which were treated by EMRS. And if you were attended by EMRS, then you tended to be younger and male, and you're also much more severely injured. And the unadjusted 30-day mortality was 11.7 versus 9.6. So you were more likely to die at 30 days if you were attended by the EMRTS, with an unadjusted odds ratio of 1.25. However, they did an adjustment for the differences in case mixes, the case mix seen between the two services. And that's where we see a real difference in those patients attended by the EMRTS. And that adjusted odds ratio showed that you had a 37% lower chance of mortality if treated by the HEMS service. So what were the strengths of this paper? So firstly, previously, evidence has been criticised for HEMS teams, including minor injury, so ISS less than 9. And so this kind of, the fact that these cases were ISS over 9 kind of eliminates the idea of over triage. The paper really nicely adjusted for case mix variables, and there was quite a large number of cases included in the trial. What were the biases and limitations? Well, the study population was limited to databases that used to the databases that were used. So, for example, TARN participating hospitals were the only ones that were included. So this might have led to a case selection bias. The study didn't include pre-hospital death. And the study, if we think about how relatable this is to LAA in our practice, it included blunt trauma only, so there was no penetrating trauma included, which makes up about 50% of the LAA workload. The transfer times are going to have been different for those patients that were flown to hospital, and it didn't really make any comment about this. And the fact, kind of, there's a big confounder, which they talk about a lot in their discussion and their conclusions with it, that, as Mike kind of referenced earlier, this is the EMRTS was part of a package, and that the enhanced decision making that the EMRTS brings to these patients is their enhanced decision making on triage and the likelihood that these patients would have been triaged to an MTC. And so what the role of the advanced care within the MTC will have brought to these patients in addition to that of the HEMS team. And we have to remember that this group were, although the majority of the data was looked at by the SAIL team at Swansea University, this group were evaluating their own service, and all of them are pre-hospital clinicians, so they do have a small vested interest in a good outcome for this evidence base. So using the CASP appraisal tool, I had a look at how I felt about the study. So did the study address a clearly focused issue? I think it was a broad but focused issue, so I said yes. Was the cohort recruited in an acceptable way? That I thought yes, definitely. They're all very well-founded data sets that were used. Was the exposure accurately measured to minimize bias? I thought it was difficult to tell, but I think that's probably the nature of recruitment in the pre-hospital world. And was the outcome accurately measured to minimize bias? Again, I think it's difficult, but and that is reflective of research in pre-hospital environment as well. Have the authors identified any all-important confounding factors? Yes, they definitely talked about that in their conclusions, and we've gone through a couple of those confounding factors. And have they taken account of these in the design? or analysis? Well, I think that that probably reflects the recruitment to TARN participating hospitals, but I think given the fact that they would have struggled to collect data if they'd used non-TARN recruiting hospitals, it would have been much more challenging for them. So I think they probably they did account for that as best possible. And was the follow-up of subjects complete enough? Well, it was 30-day mortality, so yes, it was. I definitely did believe the results, and I think that importantly, can these results be applied to our local population? I think it's really difficult because the patient population served by the Welsh Air Ambulance is quite different to that served by London's Air Ambulance, given the number of penetrating trauma patients that we see. But certainly the blunt trauma patients that London HEMS serves tend to have an ISS greater than 9. And so I do think that the evidence here is translatable to our service. And do the study results fit with other available evidence? Well, I think they kind of move on from other available evidence, and they kind of are an extension of other available evidence within that's come before them. So in conclusion, it's an important study, I think, looking at the impact of 30-day mortality in moderate to severe blunt traumatic injury. It doesn't take into account the role of triage within the system, and the fact that these patients the majority of the patients that the RTS service saw were taken to the MTC. So as Mike was saying, it's kind of a look at the whole service as opposed to just the HEMS service itself. And I suppose it kind of, again, as all research does, leads us to ask more questions. And those were kind of, what specific factors are responsible for this survival benefit? Is it the fact that the performance of time critical interventions on scene, or a rapid transfer to MTC, or advanced triage skills, or is it all of the above that comes as a big package with the HEMS service? And just to think about, maybe after we have a discussion about how we look at these and how we tease that out in future work. So as we were talking about before, I am a big supporter of I probably shouldn't say this, but I am a big supporter of dual CCP pre-hospital teams. And I think that it's really important to remember, as we were saying, that this paper is not supporting a physician CCP pre-hospital service. It's supporting a package of a HEMS critical care service being delivered to very unwell blunt trauma patients. And it probably should lead us on again to thinking about what should that be? What type of pre-hospital critical care team do these patients need? And I don't think that this paper answers that question. And these are my references. Thank you very much.
So thanks for that really nice summary of the paper, Jess. I think we can see if there's any other questions first, and then we can, I certainly have a few comments and thoughts to share and talk about. Robbie, Liz, anybody have any things you wanted to raise at the moment? Scarlett, yeah, go ahead.
I was going to say, with the MTC thing, was it not something they could have included in the results to show end destination? Because
I think, yeah, I didn't see, there wasn't anything about end destination within their results section, but they do talk about it in their kind of discussion. And so we don't know how many of those patients were taken to an MTC, but I'm guessing the majority of them probably will have been taken to an MTC, but I'm not sure about the triage tool within Wales itself.
Because then in a way, couldn't that almost undermine the whole findings of the paper? You could just say it's just because they went to an MTC if all of the one cohort went to an MTC and none of the others did. Not that it would be that weighted, but it can undermine the message.
Yeah, I totally agree. And I think that I think that they acknowledge that, but it could definitely undermine the evidence entirely. And we could just say that it was because they were taken quickly to an MTC where they got advanced care within the major trauma centre, which does totally undermine the evidence itself.
I'm curious with the comments about from sort of both of you about the sense of undermining evidence. So, Scarlett, what were you suggesting by that?
I just mean that in the title of the paper is all about what the HEMS team are doing, or the EMRTS are doing, and what kind of impact that's having to the patients. But obviously a big part of patient survival, which is the 30-day mortality that they're looking at, is going to be what happens to them while they're in hospital as well. And they do, like Jess said, they touch on it in the discussion about that they don't know whether they went to an MTC or not. But I don't think they broaden that out enough, talking about the effects that it could have had, or with using the data. I feel like in Tarn, that data is available what hospital you go to. But I might be mistaken. If that's not the case, then they wouldn't have had it available to use.
Yeah, no, I think it's 100% available. What they didn't do is they didn't include that as a factor in their multiple regression analysis.
Yeah.
So the data was available and they could have used it. I think, so this is the big question. This is the big take home for all of this. So one is, I agree, their title of the paper is probably slightly not the best title, because I think it somewhat leads people astray. But their question they ask, I think, is very clear in that their question is, does introducing this eMERTS package as designed and delivered improve the quality of care for patients? And I think one of the things that's really essential to do is take this from a patient perspective. I think a lot of people have been looking at this from, and they sort of set this up a bit with their title, from the provider perspective, because this isn't necessarily about providers. This is about how do you deliver the best and highest quality of care to these patients who suffer trauma in this setting to have the best outcomes. And I think it's like any of these sort of bundled packages of care, and this is something that's happening more and more with medicine in general as we become more complex. We've moved beyond the ability to look at simple single interventions and say, oh, this is what makes the difference. This one particular thing. We need to look at a whole package of care, and this is what we often do. So this, what this, and I would say that this study absolutely supports the use of physician paramedic combination in this system, in the eMERT structure, to deliver this result. What it has no evidence about is whether or not anything other than the current model they've delivered would have the same effect, either better or worse. So that's what we have to think about. This is the, I would have called this the bundle of service that's been delivered to patients, because it includes everything from going to the MTC, which we know is associated with the benefit in care, because there's lots of studies that have already shown that MTC care versus alternative care has better outcomes, that getting to that place directly from scene as opposed to a secondary transfer has been shown to be beneficial, that the interventions you may receive during that time and whatever allows you to survive to get there, because we're talking significant geographic distances here, unlike in London. Well, we have time differences. So all that taken together has led to this result. So if you were to apply this in your own community to try and replicate this, you sort of have to give the package. It's like you can't start to pick pieces apart. Jess, I had a question for you, two questions actually. If you were to, how would you design the study differently to answer the two questions that you were trying to answer? One about MTCs and one about the the team side of things. There are a couple of different ways, because one of the things I think is always helpful to try and do in these sessions, think, well, okay, we're going to design a study to answer a different question, or to answer the question we want to answer, how you would design it differently. So do you have any thoughts on what you would do for that?
Yeah, I think it would be useful to maybe for them to have included some information about the triage tool within the Welsh system itself, to know how those patients from a kind of ambulance service would have been triaged pre-hospitally. So maybe some, because it's difficult, isn't it? Because I suppose I'm guessing about the transfer times in Wales. They're going to be a lot longer than ours. So, but it'd be useful to know how those patients with an ISS of greater than 9 would have been triaged by the Wales Ambulance Service, and whether they would have all been necessarily taken direct to an MTC, or they would have had to have stopped at a DGH if their transfer times were slightly longer. And try, so yeah, difficult to know how you would design a study to, but I suppose taking the ones out, well, I don't know, you can't really take the ones out that go to DGHs because that's part of the package. And then I suppose the problem is from obviously with the EMRTS, they don't have a dual CCP team that are kind of working, and I don't know how many services do at the moment, but ideally it would be nice to compare whether a dual CCP, to know about the role of the doctor within the team itself, to have a look at if you could compare a doctor CCP with a dual CCP team, a HEMS team, and see what the outcomes were. Because I would expect that there probably wouldn't be a huge amount of difference, but I'm not sure whether you could do that because they clearly don't have that model within the service, this service.
Yeah, it's interesting. I think a few people's opinions may differ about the impact, but I guess the other thing you'd want to measure then is the cost effectiveness and how you would deliver that same level of care. And certainly, this is something back in North America we look at all the time, and even because there are different models there, and you can try and compare between different settings, but then you run into all different issues with the different in-hospital systems and care. So I think the things that you can think about, so when you think about designing a trial like this, so I think you're right. If you only cared about, if that was the most important thing to you, is whether a doctor makes a difference or not, which in some ways to me is a bit of a, yeah, anyways, you would have to look at, you could do that relatively easily by saying, okay, we're going to randomize days as to whether or not it's a dual CCP or physician CCP response. And then you'd have to look at all those responses across that time and see whether or not that one piece of the system that you're changing makes a difference. So that's one way that you could do it. The reasons we end up not doing things with that is because if the difference, you need such a large number of patients probably to start to identify those differences, and then logistically, and then there's issues of contamination, stuff like that. How do you have a system where you have this and you don't? It's more likely a type of system where there's been done elsewhere in the world. This is a while back, where you have one type of model, such as no physicians, and you introduce a physician, you do a pre-post or staged randomization where you start to do sort of block cluster, randomize people and introduce the service at different times in different areas so you can measure. But it gets, those types of designs get to be very complex. The MTC thing is interesting in another way, so you could do that certainly in our local setting in London. And the problem is we don't have something like SAIL and this amazing database to be able to capture this. But you could look at patients who meet a criteria for an activation of a HEMS team, for instance, that for whatever reason, the natural experiment, that team's not available, that are taken to a local hospital, local MTC with regular ambulance care versus a HEMS care, and compare those patients. And that way there you have standardization that the system, the hospitals they're going to are the same, because you have to start to control that. As you mentioned, the difference between an MTC and a non-MTC care. So it's really complex to do this kind of research. I think the biggest strength of this study is that they have this really robust data collection process in Wales to be able to aggregate all this. And just the point about the pre-hospital providers. So the involved in the study. So the only pre-hospital care provider involved in this was Professor Lockie. So all the rest of the team that were doing this are researchers from the Sale Institute, and they are one day studying diabetes impact, other day social determinants of health, and other things. So yeah, so I don't think there's all that much bias. I think this is one of the things that the government wanted this type of analysis done because they're paying for this service and they want to see the impact they're getting for their money. Robbie, do you have a comment or question?
Hi. Well, thanks, Jess. That was great. A really good review and really interesting discussion. I mean, it's more I don't know, I guess a comment. And I agree with your points with and Mike and Jess with regards to, that it's important to study this package of care and its effect. But in the same way, I think we need to sort of move on from this. I know although this is a new and expensive system, and it's important to evaluate it, I think we need to move on from this sort of approach to check or even, surprise that, you create a package of care with advanced decision makers and advanced interventional capacity that improves triage and takes patients to a center of care that they, from the evidence base you've discussed, should improve their outcome, and then sort of be surprised that patients do better. I think it's important to do it for those health economic reasons, but I think we need to move on, and trying to study this incredibly heterogeneous group like this, and then having to adjust for all these confounders, albeit with a good methodology, makes it slightly I think weaker. But moving forward, I guess my point is that if we're really going to move beyond this, and the level of care, which it's not a surprise, in hospital, we aren't surprised that senior decision makers with an advanced interventional capacity or the involvement of doctors might improve outcome. Yeah. And from a patient's perspective, it doesn't really matter if they're in hospital or out of hospital. They want to survive and get better. So yeah, moving on to in these analyses, actually figure out in the patients who do badly why they're doing badly, what they're dying from, and then focus clinical trials on specific interventions or combinations of interventions within these systems to then evolve care further. So yeah, that's a bit of a rant, but that's what I think.
Thanks, Robbie. That's insightful as usual. And yeah, I couldn't agree more with you. I think the need to move on and to focus on a patient perspective on the care that they need to receive to have the best outcomes, to decrease preventable deaths, whether they're trauma or medical. I think one of the interesting things was I was texting with Lockie about this paper in the last couple of days and asking if they're going to look at the medical side, because I think their system is not purely a trauma system. Actually, it's a small number of their patients are trauma compared to the overall care they provide. And I think there's some interesting stuff, particularly when it comes to terms of health equity, and in places like this is close to my heart because this is much more of a Canada type of issue, and the same thing we see in Australia and places with larger geographic distances. But in Wales, this is an issue of how do you try to you'll never get rid of it, obviously, but try to mitigate the gap between those that are living in large urban centers right next to the MTC versus someone who is quite distant from that, and to try and deliver some level of health equity to them. But things like sepsis and other things like that, there are lots of interesting other areas where this might be might have an impact. So they are looking into those analyses. They're just a lot more complex and less sort of straightforward than the trauma analyses because of the things like the existence of TARN for so long. And while there's things like ICNARC that look at critical care in general, it's hard to get a nice disease specific outcome that you can start to kind of compare different patients on when you get into these really heterogeneous type of critical illnesses.
Jess, just a quick question. Why do you think they excluded penetrating trauma? Because I would argue that, again, from the patient's perspective, it doesn't really matter whether the implement that struck them was blunt or penetrating. And you could argue that this system would bring just as many benefits to that group of patients in this context as blunt.
Yeah, do you have any thoughts on that, Jess?
Yeah, I wasn't sure actually. I didn't know about whether it was related to their transfer times. I wasn't sure whether those patients may have been taken to kind of more likely, if they were being transferred by road, to go to a closer hospital like a DGH and therefore weren't in a TARN reporting hospital. I wasn't quite sure about why they didn't include them in there, because I agree the information would have been equally as useful.
Yeah, and I think for me that's the one of the criticisms I do have of this, well, not a criticism, but opportunity for improvement for this paper is there's a lot more detail that could have been provided to understand things. I don't think that the TARN hospital issue is that big of a deal, just because if you look at the number of patients that they had and their total number of sample of TARN patients, it would have been nice if they'd actually they would have solved this or addressed this, but just by saying what their TARN reporting rates were across all the hospitals. They don't say that. But what you do see is when you look at the number of patients that are eliminated because TARN data isn't available, it's quite small. It's only a small percentage of their total number. Where they lose a lot of the patients, which they don't explain, and that's what I didn't quite understand, is when they're doing the narrowing down based upon data available within eMERGE data. And that was a little bit surprising to me. And they don't account for why that data wasn't available. And I think walking through with a little more detail, how they narrowed it down from, several thousand patients to 400 patients in the eMERGE side of their available data would be helpful, because that to me is where I sort of got, well, that's a pretty big reduction, and that may be missing a lot of people. I also have no idea why they didn't include penetrating trauma, aside from that maybe they were trying to address this prior criticism they've had, or other papers have had, about over triage and some of the challenges with ISS capturing severity of penetrating trauma as accurately. I don't know.
Yeah, I guess the skeptic could say, well, that it might have negatively impacted the outcome benefit, but I'm sure that's not the case.
Yeah, I'd hope that's not the case. There's bigger issues with the whole system in paper if that's the case. But I think the Professor Lyons, which isn't, I made a mistake when I first looked at this paper. I thought it was Richard Lyons, but it's not. It's a different Lyons. I can't remember his first name, from who's the guy who set up SAIL and has been doing all of this research. I think their organization's integrity is certainly on the line, more than the integrity of just eMERGE with this. So I do think that, and there's a number of checks and balances in place. So
I'm not.
I hope that wasn't the case.
No, it was more just
Robbie, can I just from what you said, I agree with you. Like, it does make sense now. We can almost feel like we can move on from kind of rehashing over all of this topic, but I do think it's really important not to put senior decision maker and advanced critical care in the same bracket as doctor, because I do really strongly feel that senior decision makers and advanced critical care can be delivered by people other than doctors. But I don't know. I know that I'm being controversial.
Yeah, no, it's a fair point, and I don't disagree. I agree. I mean, I guess in this system, probably some of the interventional capability is enabled by the fact that there are doctors there, which might, attribute some of the outcome benefit. But I agree, it doesn't mean that that couldn't be delivered by a CCP team. I guess, as we move forward into advanced, as we start to delve into why the patients that have bad outcomes do so and look for preventability, and then perhaps look to more complex interventional solutions for some of these problems, I guess I have my doubts if they could be delivered by the CCP team. When you start, when you talk, Reboa, ECMO, that kind of interventional strategy in this context. But maybe I'm wrong, and we haven't got any definite evidence that those things are actually going to benefit patients anyway. So, yeah.
I just think maybe on a broader level, not on an individual patient level, if you have CCPs work, it's more targeting the patients that are seen by the ambulance service as opposed to a HEMS team. The knowledge and the experience and the teaching that those CCPs take back to their independent ambulance services and teams, and the teaching that they deliver, may then impact on those patients that are seen by the ambulance service themselves, as opposed to the HEMS teams, the ones that we don't get sent to because we're in another job.
Yeah, no, completely agree.
I think that's a debate for another day, and probably better for a pint at the pub later, Jess, and we can happy to share my thoughts and on this with you and debate it sometime. And I think, there's lots of other factors to look at into how to develop services, how to deliver them safely, how to maintain them, and how to do it all cost effectively, and while achieving the best care for outcomes. And I think on a separate note, I think just sort of general lessons that we know about multidisciplinary teams versus unidisciplinary. I think there's a whole number of factors that fit into this whole bundle of care that was delivered that you could spend a lifetime trying to tease out. And I think what we do need to say is that I'll leave last words to Jess, but hats off to them for implementing this service, for evaluating it, asking the questions, then hopefully using this data, as Robbie says, to then continue to improve and say, okay, well, next year, how do we decrease those preventable deaths or increase the quality of outcomes by X%, and continue on that journey to continually improve the service and keep sharing that knowledge with others. Sorry.
No, I think, I agree. And with a national system of care like this, is really a great opportunity to build into, detailed analysis by consensus, by incorporating the patients who die as well before they get to hospital, which is another big problem with all of these analyses, then you can build into that national system of care the preventable death sort of analysis component, which really helps you move things forward. Because you're not excluding the patients that die before getting to hospital. And also interesting, I guess, if you have a group of patients that with like blood transfusion, for example, make it to hospital and then die, and you're bringing in another cohort of patients that get to hospital, but with a high mortality rate, you might actually negatively impact or skew the data negatively in terms of your EMRTS team, So it's important, if you're going to make a assessment of it, that you have to really look at the whole cohort, and missing that group that die is another fundamental problem with this sort of thing. But I agree, it's a good paper.
Yeah, and completely agree about the lack of those data about the deaths, and I think that's more of was certainly in the UK, but of a pragmatic challenge with coroners-based systems and different silos of information, but something next to hopefully for them maybe to be able to look at addressing. And certainly an organization such as SAIL would probably be the first group that could potentially do this and start to collect that data. So that'd be great. Jess, over to you to close off for this session.
Well, I think that in conclusion, it's a really useful study. and hopefully it means that we can kind of move on from this question, and that I suppose, as Robbie has said, start looking at the reasons the patients are dying and how we improve their care going forward.
Well, thanks everyone for coming. And next month, an exciting international journal club with the Norwegians, and another will definitely be controversial topic. So take care. Bye-bye.
Well done, Jess. Thanks.
Thank you.